As we start another day of filming, I've been reflecting on the past few years, and I've realized that these video updates are kind of like a baby. We conceive the various topics we're going to include, we do a lot of preparation and groundwork to make sure everything is just perfect for that special day, and then we go through the laborious process of filming and editing until we finally give birth to a shiny new video. And then it starts to cry, and it's hungry all the time, and there's diapers and blooper footage to change. And then it asks for all your money, and then it grows up, and then you have to drive it everywhere, and then it goes to college, and then you miss it. Hang on a second, I think I'm losing control of my metaphor. Anyway, since we're talking about babies, we figured this would be a great month to hang out at the brand new Regions Hospital Birth Center. We'll take a quick look around, ask a few questions, and then learn how to sort out the moms from the babies. And of course, this wouldn't be an update video without the latest from the news desk. So I'm Dr. Peterson with Regions EMS, in case you haven't figured that out by now. And stay tuned because you're not going to want to miss this Regions EMS update video. And we're back. Oh, hey, this is great timing. You look like you're important around here. Tell us who you are and what you do.
My name is Emery Malione, and I am the Labor and Delivery Nurse Manager here at Regions Family Birth Center.
Perfect. Do you mind if we ask you a few questions as long as we've got all this stuff set up here?
Sure.
So first of all, I know this is a question that all of our pre-hospital providers have been wanting to know for a long time. Where do babies come from? I'm just kidding. So how about this? Tell us what happens when an ambulance crew brings a patient in labor here to the Regions Hospital Birth Center.
All right, so ideally if they call MRCC first, they'll give us a heads up, and we will have one of our nurses come down to this lobby and meet them right here so they can assess where they need to go. Then they will go through our locked doors, as we are a closed unit for the safety of our babies, and bring them up to our triage area on the 3rd floor.
So it's not on this floor?
It's not on this floor.
So there's some elevators involved?
Correct.
Okay. Would there ever be a situation where the crews should stop in the ER rather than coming here, or is it always going to be here?
I think if you have a pregnant person who's had any sort of trauma, that we want to make sure that they're stable medically first, then they would go to the ER. So if you've had a significant car accident or any surgical injuries that we might want to assess first, then they go there first. Okay. Otherwise, if we have somebody who's stable medically but is coming in to be evaluated for labor, they would come here.
Perfect. What happens if they come in the middle of the night? Is this building open? How do they get in?
Yep, same thing. Our building is open 24 hours a day, and at the night time we have our security guards down here to help with the guests coming in and out and coming through the same front door.
Have they had to deliver any babies?
The security guards?
Yeah.
Not that I'm aware of.
How many babies have delivered here in the lobby?
So far, none.
None.
In this birth center.
And how long have you been open?
We have been open for a little over a year. We opened in July of last year.
So you're saying it's possible, though, that could happen?
I mean, that's always possible.
So what's your typical daily census here? How many births do you have per day? How many active laboring moms do you have? Some basic stats.
Sure. Honestly, it changes a lot day to day. Our average births had prior to this new building been about 200 to 230, but last month we hit our all-time record at 268. So
per year, not per day, right?
In a month.
Okay, in a month?
Yeah,
okay.
yeah.
Okay.
So I would say on average we have maybe 8 to 9 babies in a 24-hour period is typically how that goes.
Okay.
I think our highest ever was 16 in a 24-hour period.
So it's a busy day.
Yeah, it's busy.
Okay. Is there anything else that you would like our EMS providers to know about the birth center, or just about things that you've seen managing labor and delivery situations in the field?
Yeah, I would say one thing that we really love about our space is that we actually have a physical space now that kind of embodies the care that we try to give to our patients. We're really looking at family-centered, equitable, and highly reliable care. We have interpreter services available 24 hours a day, so if they have a patient who doesn't speak English, we can help manage the communication. I would say from an EMS perspective, one of the things that I've seen that from a medical perspective is most concerning is making sure that if that baby delivers at home or in the rig, to keep that baby warm until they get here. So best way to do that, put maybe right on mom's chest, cover them both up with warm blankets. I think that's probably the most common kind of hiccup that I've seen before.
Sure, sure. And that's great because, you know, birthing is a very natural process that usually doesn't require any medical interventions, but there are some simple things that we sometimes forget just because it's an emotional, you know, exciting moment. And so that's a very good point to remind our providers for.
Yeah.
And then last question before we head out of here. I've always wondered this, how do you tell the boys from the girls when they're born? Sorry. Thanks, Emery, for your time. Thanks for your input, your support of our EMS providers, and we look forward to working with you in the future.
Thank you. Appreciate it.
Dr. Apgar was a member of the medical staff. At 28 years old, she was named director of the Division of Anesthesia within the Department of Surgery here at Presbyterian Columbia. What she's known for, of course, is the development of the Apgar score. The Apgar score is assessed at 1 minute and 5 minutes. 1 minute of life, the person doing the assessment, usually a nurse or a physician, assesses the baby's heart rate, how well the baby's breathing, the muscle tone, how the baby responds to stimulus, and finally the color. Each of those 5 elements gets a score of 0, 1, or 2. A medical student asked her in Presbyterian Hospital in 1951 or 2 how she would assess the health of a newborn. And she said, well, that should be easy. And she, on the back of an envelope, she wrote, well, we'll look at the heart rate and the breathing and other components of health. And she legendarily came up with the score at that moment. The Apgar score, as far as I know, is used everywhere. She was a musician. She played the violin and viola. I know that she also learned to fly. She wrote a popular book called Is My Baby All Right? She led the March of Dimes, then later the National Foundation, to fight birth defects in children. I do think that before the score was developed, if a baby was born and was a little bit blue and wasn't breathing that well, they said, well, they put it aside and basically looked back at it in an hour and saw how it was doing. And sometimes that baby would be okay, and most of the time I suspect not. I think there's no question that millions have been saved simply by the need to assess the baby at birth. I've been here in obstetric anesthesia since 1993. It's been very nice to be in the division that she founded, and I am now the Virginia Apgar MD Professor of Anesthesiology at Columbia, which is actually a pretty cool title.
This little baby girl was born just a little over an hour ago. I do think that a very good person to give the score in the delivery room is the circulating nurse. Mrs. Angle, I know you are a student nurse and you haven't met the scoring system before, so let's just run over the 5 points of it. How do you think you go about telling pulse rate in 1 minute after birth?
Well, 1 minute after birth, the cord, of course, would be longer and pulsating, and I could hold on to the cord itself. Also, another way would be to place my finger in the epigastrum and press so that I could feel the aorta and pulsation there. If I still wasn't satisfied, though, I could go ahead and put on a stethoscope like we're learning in school, and I could put it over the apex of the heart.
Okay.
This is mighty rapid. Can you tell by my finger how much?
Well, I'm sure it's over 100. And this baby would get a score of 2 for that if it were true at 1 minute. What would it be if it were a score of 0?
Oh, there would be an absence of pulsation, or very weak to the point where I'd need to check with a stethoscope, and there...
You wouldn't even hear it.
I wouldn't hear it at all.
Score 0. That's right. Score 1 would be a slow heart rate, irregular slow heart rate at 1 minute after birth. The second important sign is respiration. How would you go about, Mrs. Angle, judging this respiration 1 minute after birth?
Well, I was observing you right after birth. The 1 minute, she was screaming vigorously. But now when you're teaching me this, it's an hour later, so if at that time she was, the 1 minute after birth, if she had been breathing like she is now with no crying, well, I would have put my fingers on the diaphragm and the upper part of the chest gently so that I could see the movement of her breathing and also feel the respiratory breathing at this time.
What would a score of 0 look like, Mrs. Angle?
In 0, I would think that there would be an absence of breathing And as far as observing for it, there would be no up and down movement of the chest. And to touch it, I would not be able to feel anything. But this would have to be real fast because she's going to need help at this point.
That's right. One should be resuscitating her already. That's right.
But this baby, of course, was fine.
Yes, we're just talking about theoretical babies.
Right.
Another important sign is muscle tone. How do you think, Mrs. Angle, would judge muscle tone 1 minute after birth?
Well, I would think that muscle tone, you'd have to judge that from observation alone. And if the baby's muscles, like if this baby, she has good muscle tone. You can see the way she flexes her legs and she flexes her arms and moves them about. And also her general body seems to be firm with muscle tone. Now,
how about a score of 0? What would that look like?
Now, I would think that would be flaccid, completely like a limp dish rag. And at that time, then I might want to stimulate her in some way.
Then a score of 1 would be sort of in between.
This is the one that I wonder about. You can see like she's very active for the score of 2, and for the 0 score would be such an extreme. But what about the 1 score?
Well, I think the score of 1, we'll call it a rather limp but moving some. Score of 0 doesn't move at all. It's just blah. Another sign to test for is reflex irritability. What do you suggest is the way that we could stimulate reflexes?
Well, from what we've learned and I've done before, which usually works, is to snap her hard on the bottom of the foot.
She liked that, didn't she?
But she seemed to like it instead of responding.
Maybe I'll show you another way that might work.
That was a good 2 reaction for this baby.
It certainly was. What would a 0 reaction be for reflexes?
Well, if this baby was a 0, I would think that she would have no response at all.
That's right. And 1 would be what?
Well, on a 1, if the baby was 1, I would try to stimulate her, and no matter what I'd do, she'd still just sort of give me a half make of her face.
Half-hearted response.
Right, half-hearted. She'd be grimace, as the term is applied.
That's right. The 5th sign, and I think the one that is the least important, though, is color. How would you go about judging the color of the baby, Mrs. Angle, 1 minute after birth?
Well, 1 minute after birth, there's so many different color changes throughout the body that the best place for us to tell would be in the hands, and like in the palms of the hands, and you see her muscle tone, as we said, was good. And also another place would be on the feet, but don't be shocked, this is not cyanosis. This is the good color. This is the footprint that I put on while you were gone. Yes.
And the lips are a good place too, I think. This baby actually 1 minute after birth, it's been an hour now since she was born, did have blue hands and feet, and there was 1 point taken off of her total score for that. Her total score was 9. By now, you can see she has cleared up that sign completely. Many babies have 1 point taken off, and the average score, the most important score, is 9 in many different hospitals.
Well, what would be the in-between color, like she's pink, or for a 2?
Well, for 2, she'd be pink all over, hands, feet, head, trunk, everything. 1 would be blue hands and feet, the rest of her pink, and a score of 0 would be just pale blue and all over.
Body.
Right. I think this demonstration shows how easy it is to teach these 5 points in the scoring system. This young lady who's a student nurse had never heard of the system until this morning, and I think now she has a very good grasp of it.
So Kevin, Asauskas, Asa, you just need a normal name like Bjorn or something like that. So Kevin, we're here in Woodbury with Kevin Asauskas, one of the fire commanders, also a former police officer. So tell us a little bit about your background here at Woodbury and how you got involved with EMS.
Yeah, I say they always gave me a badge number because of my last name. But yeah, I started with Woodbury as a police officer, and 2 years in I went to paramedic school, and I was one of our cross-trained police officer paramedics. I was a police officer for 16 years until I jumped over to the EMS fireside full-time. And yeah, so in that 16 years, did both roles for 14. So
you would arrest the bad guys and then treat them for their breathing issues or whatever.
Yep,
Okay.
Exactly.
Awesome. So as a former police officer, we want to tap into some of your experience searching a person for a weapon. We have gotten some feedback from time to time from the EDs that patients show up with a weapon that was not known about by the EMS provider. A more recent story is that a knife showed up on an x-ray. So that wasn't even noticed right away in the ED either. What are some things that we can do as EMS professionals to keep ourselves safe in those situations, knowing that we're going to be locked in the back of a box with that person and that weapon for a period of time?
Exactly, and there's no easy answer to it. It is complicated, but definitely coming out of paramedic school and hearing make sure the scene's safe, include law enforcement. We know that there's dynamic situations that don't even allow that sometimes. So the biggest thing I would transfer over from law enforcement to EMS is a contact and cover concept of, and it really is just situational awareness and not getting tunnel visioned. We talked about that all the time with medicals, but bigger picture of your scene of contact cover. If there were 2 officers on scene, one person make contact with that person and be focused on that. The other would be taking in the 360 degrees and being aware of exactly what's going on. Sure. So right there, that's the biggest thing. It changes a little bit when you're one-on-one in the back of the ambulance, but for right there, staying situationally aware is a huge part of it. Sure. I mean, even going from just not going right to the laptop and typing, being aware of everything that's going on your scene around you.
So that's where a lazy eye might be a bonus. You could keep one eye on the patient and one eye on what you're doing.
Yeah, if you got that ability.
All right. Everybody has their go-to question when we ask certain things. You know, what's your past medical history? Do you have any medical issues? Any medical issues that I should know about? That kind of thing. What question have you developed in your practice as far as asking about weapons from your history as a police officer?
So even as a police officer, when we search someone before putting them in the back of our police car, we would ask them, is there anything that you have that could harm me or you? And sometimes they'd be very forthright with saying that. I mean, once again, there's weapons on people that are good and bad people. We talk about EMT firefighters that walk around, everybody's carrying a knife. And once again, with concealed carry, there's a lot of concealed guns out there that people with no ill intent may have on them, but.
Right, and I think that's the key, is it's not often ill intent, it's just an incidental weapon, but depending on the call, you never know how things are gonna shake out and play out in the back of the box, right?
So I think a big part of it is staying calm as you address this issue. And simply asking that of, do you have anything that would hurt you or myself on you right now? And seeing if they're forthcoming.
Sure.
Now then that goes into, we don't want them reaching for that, we don't want any, so simply communicating that as well.
Sure. But, so now what happens if you find something? Let's start with something simple like a knife, something common that a lot of people might have on them for various legitimate reasons.
Right. Now, I look at this a couple different ways. If you're outside on a scene with law enforcement, obviously include them. Once again, if you got a conscious or unconscious patient, different deal, right? But that conscious patient who you see that on them, I think right away you involve your partner. You don't do this alone, one-on-one in the back. If you've got someone who's seemingly cooperative, you can simply ask them to remove that and we'll hold on to their belongings, they'll get it back.
Sure.
Otherwise, if you see that, you've got somewhat of an unknown, maybe a mildly agitated patient, definitely communicate that with your partner, communicate that with law enforcement if they're available, because you want those resources there before you address that. As a police officer, if you go hands-on or touch someone, that's when that moment changes. So that is a dynamic situation. So if you're able to have those resources.
Sure. Now, the nightmare situation would be a gun,
yes.
Especially with a mental health situation or just someone who's aggressive and agitated and just pulls out a weapon, a pistol or a gun or something. Not talking about self-defense, but let's say they surrender the weapon or you find it incidentally, what next?
Yeah, now, if they surrender it or somehow that is separated from the person, I would say the biggest thing there is don't try unloading it, don't try manipulating it. Even with a gun, it's holding it by the stock with your 2 fingers, nothing near a trigger, and putting it just somewhere away safe, maybe in a cabinet or something until you do get law enforcement to handle that. So,
and I know a lot of agencies have policies and SOPs for that kind of a thing, and some even have a lockbox in the ambulance that is designated for weapons like that. What about like if you have a narc safe? I mean, is that appropriate?
Yep. And if not, somewhere completely out of reach or sight, etc.
Okay. And then documentation obviously is key in these situations too. Just so you identify that you found it, here's what we did with it, and then obviously if it goes missing later, you want to make sure that you've covered your back and said what you did with that weapon.
Yeah, and I think it's important to note too, as I talk about self-awareness, situational awareness. A lot of the times if someone's carrying a gun that shouldn't be, it's going to be on their dominant side. So wherever someone's not wearing their watch, but a lot of the times they don't carry it with a typical holster or anything. It might be tucked in. A lot of times people will readjust or they'll give some cues to that, physical cues. So it's really watch the hands and watch the person versus, once again, laptop or other things.
Sure, okay. So now you show up at the hospital, you got a gun, you got a knife, something off the patient. What do you do with it when you get to the hospital? Yeah,
once again, I would definitely notify hospital security prior to getting there, trying to get them involved, just know what the situation is. And once again, law enforcement, you might even have law enforcement at that hospital that can assist with security, but don't further manipulate the weapon or mess with it at all. Just bring in your patient like you would normally do, but make sure there's a good verbal handoff with security, hospital security, and hospital staff even prior to you opening the doors of the ambulance.
Sure. Well, thanks, Kevin, for your great insight. Any last words of wisdom that you'd give responders?
No, I think it really is. I keep hitting on it. I see so often of people right away getting on the laptop and staying on that. It really is watch that patient. And I think the biggest thing for me that I'd always see before there was some, whether it be someone fleeing or pre-attack indicator, is that someone takes a deep breath and they look around, like scoping out what's around them in that moment. So watch people's hands, watch people's movements, and once again, more hands when you've got a situation like that. And then also the last thing is it's not a bad thing to remember to remove yourself from that dangerous situation. There's nothing wrong with totally leaving that situation. Sure.
What's the strangest thing you've ever found on someone?
Yeah, that's a good question. Over the years, I think what surprised me a lot of times was like someone had, I like to call them ninja throwing stars because I don't know what the actual term is besides throwing stars. But I always thought to myself, what are you going to do with that? But other than that, I think it was the prevalence of people carrying like stun guns. I also think, what are you going to? So, I mean, besides the regular knives and guns, but they were unique where I go, that's your thing.
Sure. All right. Well, thanks, Kevin.
Yeah, thank you.
Hello, I'm Dr. Peterson, and this is a Regions EMS Studio Update. Now, it's been a minute since we've done this, so there's quite a bit to cover. You ready? Buckle up. Here we go. Remember how last time I told you that we were going to get rid of divert? Well, that happened. Not sure if you noticed. As of January 3rd, 2022 at 0700 hours, the Twin Cities metro area no longer allows a hospital ED to go on divert. As long as a hospital is open for walk-in ED patients, it will be open for ambulance patients. We have been monitoring offload times, hospital census information, and critical events, and wouldn't you know it, the Earth is still spinning. We feel this is a huge win for EMS and patient autonomy, and hopefully has made your job a little easier. That said, please reach out if you experience any unexpected issues or situations. ECMO is back at Regions. I could use the well-worn pandemic excuse for the on-again, off-again issues, but let's not focus on the past. Let's look forward to a world where everyone in the East Metro has access to ECMO. Some of you were able to sneak into the University of Minnesota Hospital with an ECMO patient during the last 2 years, but now that the mobile team is active again, you will likely be directed to Regions Hospital for cannulation. Just to recap, the mobile ECMO team includes an ECMO physician as well as a paramedic or nurse from LifeLink who will respond to the ED with specialized equipment. Once a patient has been evaluated and determined to meet criteria, they will be able to place the ECMO catheters, start the pump, and provide ongoing stabilization and treatment. Ultimately, at least for now, these patients will eventually be transferred to the university hospital, but at least we're able to get them on ECMO sooner with this resource available at Regions. You can see the inclusion criteria on the screen, but if there is any uncertainty, do not hesitate to call and let the ECMO doc make the decision. The ECMO team is dispatched through LifeLink Dispatch, so the phone number will connect you with the LifeLink Comm Center and just state that you have an ECMO patient. They will either direct you where to go or connect you with the ECMO doc for a consultation. Your job is to first recognize an ECMO patient early, second, activate the ECMO team, and third, package and transport the patient as quickly as possible. Ideally, we'd like the on-scene times to be less than 15 minutes. Also, based on several years of ECMO experience to this point, endotracheal tubes are preferred over iGels, and your Lucas device should be in 30-2 mode instead of continuous compressions mode. This combination seems to provide better oxygenation, which increases the chance of a good outcome. We're very excited about this and look forward to providing you with more data as it is available. Okay, as if COVID-19, murder hornets, and ridiculous gas prices weren't enough, now we're hearing about monkeypox. Seriously? Monkeypox. You just can't make this stuff up. Here's what you need to know right now. Monkeypox is a virus that originated in Africa and is related to the smallpox virus, although it's considered to be much less severe. It has an incubation period of 1 to 2 weeks, followed by the typical viral symptoms of fever, chills, headache, and fatigue. The classic symptoms for monkeypox include swollen lymph nodes and ultimately the development of an extensive rash similar to other pox infections like chickenpox. Infection is spread through direct contact with body fluids or prolonged face-to-face encounters. Although it can be serious, currently we do not expect to see widespread outbreaks. Isolated cases will probably continue, but this should not be a reason for any of us to be concerned at this time. Fortunately, anyone with a fever and a rash should prompt you to take extra infection control measures anyways, such as a mask and a gown, so this shouldn't really be a change from our current best practice. The team here at Regions EMS will keep you updated as needed, just like we did during the early part of the COVID-19 outbreak. But for now, there are no changes to our clinical practice. But seriously, monkeypox? All right, it's that time of year when the medical education cycle resets itself, which means we will be saying goodbye, adios, au revoir, and sayonara to Dr. Joe Lippert. Many of you have had the chance to interact with him as he has been very active with all of our agencies and a strong champion for our ultrasound initiative. Dr. Lippert will be heading back to Omaha, Nebraska to join several other previous Regions EMS fellows, such as Dr. Eric Ernest and Dr. Abe Campos. Best of luck to you, Joe, and thanks for all you've done this year. Looking ahead, we're excited to welcome Dr. Haley Taormina as our next EMS fellow in July. Dr. Taormina comes to us from the University of Wisconsin Emergency Medicine Residency Program in Madison. She will be a dynamic addition to our team, and we look forward to the coming year. And last but certainly not least, I would like to recognize Dr. R.J. Frasconi's retirement on April 1st of this year and publicly acknowledge his immense and immeasurable contribution to EMS systems locally, regionally, and nationally. It would be impossible to give an adequate summary of everything he has done over a medical career spanning well over 40 years. RJ has been a mentor, a friend, a leader, and most importantly, a tireless advocate for patients paramedics, and all of public safety. If you would, I'd like to ask you to join me in a toast by raising a coffee, a radio, a Halligan, or whatever you're holding. To Dr. Frasconi and a well-deserved retirement, best wishes, warmest regards, and a heartfelt thank you.
Well, that's it for this month. Hopefully you picked up something useful. And from reading the comments, I should probably clarify that in no way was I implying during the intro segment that filming a video is in any way similar to having a baby. Come on, people, I'm not that ignorant. Well, for this month's trivia question, let's stick with the neonatal theme. Although there are several types of twins, what is the incidence of somebody delivering monoamniotic, monochorionic twins? Is it A, 1 in 250, B, 1 in 1,000, C, 1 in 10,000, or D, 1 in 50,000? Send your best guess to regionsems@healthpartners.com for a chance at fame and glory in our next video. Hey, we appreciate each and every one of you for keeping us safe and for everything you do day to day. Our Regions EMS team is here to support you, so please do not hesitate to reach out with any questions or concerns. I'll let you get back to work now because I know you've probably missed at least 5 or 6 calls by now. As always, for the entire Regions EMS team, I'm Dr. Peterson. Thanks for watching. Stay smart, stay safe, and stay professional. We'll see you next month.